The Centre for Brain Injury Rehabilitation is situated in the Royal Victoria Hospital in Dundee. We provide inpatient rehabilitation for adults aged 16 to 65 years of age who have had an acquired brain injury. We are a Tayside-wide service and admit people from across Tayside. Our core team includes nurses, doctors, occupational therapists, physiotherapists, speech and language therapists, technical instructors, a clinical neuropsychologist, artist, dietitian, rehabilitation assistant and pharmacist.
Most of the patients who come here have had a head injury or a brain hemorrhage or a stroke, and obviously these are potentially quite serious conditions. Many people who go into Ninewells with these conditions are able to go home after the care that they receive there. But some people need a bit more than that, and what they need is rehabilitation. And rehabilitation is quite simply the process by which we help people to recover as much as possible of their previous function and independence, with a view to going home and being able to pick up the pieces of their lives again. Obviously, this is something that takes a while. It's not something that's done in a few days. It can take weeks or months or even occasionally longer. And this unit is for people who've had a brain injury at a relatively young time in their lives, when they're younger adults, in other words, when they're under the age of 65. When a consultant at Ninewells and his team feel that they've done all they can to help somebody with a head injury or a brain hemorrhage or a stroke, they'll ask us to come and have a look at the patient, and I then go and see the patient and meet the family and discuss what we can offer at the CBIR, the Centre for Brain Injury Rehabilitation. Other members of the team will usually also come and visit, or at the very least make contact with their opposite numbers at Ninewells, and we gather quite a lot of information about the problem which the person has and the sorts of things which we might be able to do to help. And if we are able to help, and if the patient wants to come across to us, then we arrange that as soon as a bed becomes available.
I'm Peter Bailey. I was in the centre for 8 months from the end of 2002. Well, I had a stroke in November 2002. I was in Ninewells for a few weeks, and then I came here, I think in December, and was here for about 8 months. The first thing you notice is the scale of the hospital is much smaller, of course. And when I came here, it was much more like a small country hospital. And even though I was still being wheeled about, I very quickly got the layout of the building and felt I knew where I was in the building.
I'm Norma Anderson, and I was at the centre for 4 months. I was going to bed, had new slippers on, and fell down the stairs.
Norma didn't want to come. I remember once at PRI kicking me, "I'm not going down there, I'm going." I says, "I couldn't take you home, Norma. You're not ready to come home." I couldn't cope with it. But no, once we got here, that was the place to be.
Well, I mean, I couldn't go to the bank, I couldn't go into town on my own. I didn't remember what shopping I needed. But all that's come back to me, and I now go out on my own. Walk into town and walk home. If I do nothing, at least I'm out and I'm having exercise.
The people I'd met who was looking after were just wonderful. Always interested in what was doing and how you were as well. They were very caring. I remember sometime they'd come up to me and saying, "Look, you should have a night off and have a rest." But I knew Norma would be there if it was for me. If the same thing happened to me, I knew Norma would do the same for me. I remember taking out the first time Norma went down to the River Tay to the railway bridge, and how she just enjoyed getting out in the fresh air. But the more she got out, the better I felt she was improving. Even for a night at home and in 2 nights, I felt she was improving more.
I think one of the things that I found very helpful was preparing you to go home. I was first of all let out for 1 day, then 2 days, and then before discharge I had 2 days during the week and 2 weekdays at the weekend the same week. Excellently.
Well, my wife and children came up to speak to the psychologists once or twice, who explained some of the problems that I might be going through and some of the external features of that, and to give them a better understanding. and also to give me an understanding of how the family would be trying to cope and the difficulties that they faced. The most difficult part was not knowing how long I would be here, and one of the things that becomes very clear is that the staff therapists can't tell you how long you'll be here. They really don't know until towards the end when they see how you're progressing. So the difficulty is the indeterminate time when you come here, and also that you know you're going to be here for quite a long time, and not knowing how long is quite difficult.
People often stay in the unit for a fair length of time. An average would be about 4 months, although it does vary quite a lot from person to person. 90% are able to go home from here, so we must be doing something right, because we are getting people, for example, up on their feet again, or able to look after themselves, or able to speak when they've had problems with their speech, or able to think things out or plan things on a day-to-day basis, which is often something that's badly affected by a brain injury, and which is quite disabling in terms of everyday life. If we all think about what we need to do just to get through a day, and imagine how the loss of the ability to plan and organise and think and remember and talk to people and concentrate on things can be so disabling, then we can see why rehabilitation is actually so important to help people get their lives back after a brain injury.
The role of the nurse is really the first point of contact for the patients, and this really happens even when the patient is in Ninewells or another hospital, that the nurse who would be their name nurse would go and visit them there and introduce themselves to the patient and to the family while they're there, just to reassure them about the service. When the patient comes to the unit, they would be allocated a named nurse, and this nurse is someone who would be with them throughout their stay here. They would be their first point of contact for any problems that the patient or indeed the family might have, and they would coordinate all their care while they are here. The patient would also be allocated an associate nurse who would be here in the absence of the named nurse and would have a role in coordinating the care too. Patients with acquired brain injury have a variety of problems when they come to the unit. Problems such as feeding, and the nurse would assist with helping the patient if they have a nasogastric tube or a PEG tube in situ to help them to have an adequate nutritional intake. They would also help the patient if they had mobility problems or problems with memory or problems with washing and dressing, taking their medication in an effective way. And the nurse's key role is to assist the patient in overcoming these problems. We also have a rehabilitation assistant who works within the nursing team, and she's mainly involved with social activities for the patients and helps with taking patients out on visits and playing games with the patients or helping with a variety of things. We also have a snoozling room which we have nurses involved in, which helps patients to relax while they're in the unit. The snoozling room is an area within the unit which is a place primarily for patients to relax in. It's a multi-sensory area with music and light and touch that patients can go to and just have some time out to relax. We have formal relaxation sessions there, but also the patients are encouraged to use it at different times for relaxation.
The role of the occupational therapist, simply anything that you do from the time you get up in the morning till the time you go to bed at night, any functional activities that you undertake, it's the role of the OT to try and help you to regain these skills. Following brain injury, patients have multiple problems. Problems with getting dressed, making meals, shopping, laundry, housework, returning to work, taking part in social activities and leisure activities. OTs generally would be willing to engage in any activity that's going to help the patient to regain function or maintain the function that they've got. We often have to start off with lots of pen and paper type exercises and then progress on to more functional activities. We also participate in games and remedial activities with the patients and try and encourage them to use their hobbies that they had previously for rehabilitation. More and more we're using the computer as part of the patient's rehabilitation, and there's a lot of good programmes now available for cognitive skills. Making meals, we start from maybe making a hot drink and then we would grade that up to making a full meal. We're also involved in community living skills. That can be shopping, money handling, road safety. Going home, we try to practice the skills in OT, and then we would try a graded return home, practicing these skills at home. We start off maybe with a half hour at home and then progress on to an overnight stay until we feel that the patient is able then to return home with or without the support that they require. We look at transferring on and off your toilet, on and off your bed, in and out of your chair, just very simple things that you take for granted before you actually have a brain injury. Initially, the OT would see the patient for assessment and rehabilitation. But as the patient progresses into the rehabilitation, it would generally be a half hour with the OT in any one day and a half hour with the technical instructors. I think it's important to note that the technical instructors are invaluable in the OT department, and they help us to continue with the rehabilitation programmes that are set up for the patients.
The aim of physiotherapy is to enable you to improve physically through movement and exercise. On the day of your transfer to the centre, you will meet your physiotherapist, who will assess your mobility. For example, how much assistance you may need to get in and out of bed, or how much assistance you need to stand. The following day, a full physiotherapy assessment will be carried out in the physiotherapy gym. This will highlight any physical problems that you may have, and from this, the physiotherapist will plan the physiotherapy treatment that you require. Physiotherapy within the Centre for Brain Injury takes many forms, depending on your needs. You may require physiotherapy to help improve your balance and coordination, improve strength and movement in your muscles, or retrain your ability to stand and walk. How often you have physiotherapy varies from person to person and depends on your need. Many patients will receive daily physiotherapy, Monday to Friday, with some people receiving 2 physiotherapy sessions each day. At all stages of your rehabilitation, the physiotherapist will discuss your treatment and your progress. Your family are also welcome to arrange to come along to physiotherapy treatment sessions if you wish.
Around 3/4, or maybe even a little bit more, of our patients have involvement with speech and language therapists at some time during their stay. Our main purpose is to help people to engage in useful and rewarding communication, and we mean communication in the very broadest sense. We don't only work on speech, but we're looking at listening, understanding, reading and writing. First of all, we try to establish through assessment why somebody is having difficulties, and that can take some time. Then, through therapy tasks, we try to improve the area of difficulty or find ways of getting round that impairment. The tasks we do are very varied, but are often a bit like word puzzles. We use the computer a lot in therapy, and even people with no previous computer experience usually enjoy that. When we're finding a way of getting around a problem, that can include helping people to use things like gestures, drawings, word books, maps and pictures to help them out. There are lots of different reasons why communication can be difficult, and that's because lots of different parts of the brain are involved in communication. Some people have difficulties with language. That's difficulty understanding words, difficulty finding words, difficulty using words. Some people, their difficulties are with concentration or thinking or remembering what to say. Others have problems actually moving the speech organs, the articulators, their lips, their tongue and their voice. Communication virtually always involves at least two people, and it's often important that we work with the communication partners of our patients, not just the patients. That's why we're often working with families and friends as well as patients. Because communication is our focus, some people find speech and language therapy a good place to talk about what's happened to them and to talk about how they're feeling. So we do quite a lot of listening as well. Sometimes we do group work with psychology and OT, and that's great fun, patients working together to help each other. And we run groups on things like problem solving and social communication. Speech therapists are also involved with other members of the team to look at the safety and efficiency of people's swallowing. That's their eating and drinking.
First of all, it's important to say that not everybody who comes to CBIR will necessarily see a psychologist. The team here will let me know if there are people they think could do with particular types of assistance. And one of my main jobs is to help assess the thinking skills and the emotions and behaviour changes which might happen to people after they've had an illness of the brain or an injury to the brain. And the thinking skills that we'll be looking at would be things like memory and concentration, planning and organising skills, and the person's ability to be aware of the changes that have happened to them after their injury or illness. By looking at those and assessing the strengths and weaknesses the person has, we can help to direct the rehabilitation programme to build on the weaknesses and use the strengths. I'm also involved in looking at emotional changes, and we can assess how people are managing with those and sometimes put into place some help for that. That might be on a one-to-one basis in a session with me, or it might be that I'm giving some advice to the staff who are supporting people. I can also offer some sessions to relatives to find out how they're adjusting to the big changes that happen when a loved one is in hospital. I think we could do a bit more. Not everyone will come to psychology sessions, and some people's psychology sessions will only be occasional, whilst others, if we've identified some things that we need to work on, might come to psychology 2 or 3 times a week.
My role as artist in the CBIR involves organising art workshops for patients, either on a one-to-one session or coming along to a group art workshop. The type of art activities the patients participate in involves learning about painting, drawing, and some basic printmaking. The benefits from working in this way allows patients to value other ways of communicating, other ways of learning to express how they feel. Sometimes they may find it hard to say the words, and through some of the mark making and the images that they make, they can find another way to say what they're meaning, and this can then give them a confidence they can start to build on. There's a few patients at the moment who have been in over a period of several months. Depending on their disability, the progression of their work is very noticeable to them. What I'll do is I'll show them their work from the beginning right through to the end, and they start to see that development occurring. There are concerns that people have. People sometimes say they can't draw, or they've no talent, or they never were good at drawing. And my approach is to encourage them to experience art in a way that is like a new experience for them. And it's to say to them that it's the actual process of making the work and the journey that from the beginning to the end that's important, and not so much the end result. I think that in itself helps them to feel more at ease when making a piece of artwork. If you squeeze it, it will release more ink.
My role as a dietitian is to ensure that all patients admitted to the unit are in optimal nutritional health so that they can gain maximum benefit from the therapy offered within the unit. Patients, when they are admitted, all undergo simple nutritional screening to identify any nutritional problems. And thereafter, I would liaise with the patient, with any relatives, and with other members of the multidisciplinary team to try and ensure that any nutritional problems are dealt with and that a patient's nutritional requirements are met. So every individual coming into the unit will have a specific nutrition care plan. Patients may come in with swallowing problems as a result of their brain injury, necessitating a close liaison with the speech and language therapist to devise appropriate texture-modified diets. Patients may also come in unable to swallow at all and requiring complete nutrition via tube directly into the stomach, in which case I would assess somebody's nutritional requirements and ensure that their total nutritional needs are met. Other patients may come in underweight as a result possibly of prolonged hospital stay, in which case I will work closely with the patients to try and ensure that the nutritional needs are met. And this may be through dietary fortification of everyday foods or using proprietary nutritional products. At the opposite end of the spectrum, patients may also be overweight, which can have long-term consequences for their health and also can impair someone's ability to mobilise. So I would work closely with the individual and families and the other members of the multidisciplinary team to try and agree a suitable weight management programme for somebody who is overweight, allowing them then to get maximum benefit from their rehabilitation programme. From the nutritional point of view, we try to encourage everybody within the unit to follow a healthy eating plan. And this can be followed through in occupational therapy, where patients can learn kitchen skills, and through menu planning and shopping, also as part of the therapy. Whilst we encourage healthy eating, we do recognise the fact that eating is a sociable pastime and that this is normally a time of great upheaval for families. So we are flexible in our approach to eating and encourage the social side of eating.
We hope you have enjoyed this programme about the Centre for Brain Injury Rehabilitation at the Royal Victoria Hospital in Dundee, and that you have found the information helpful. If you have any questions or queries, do not hesitate to contact the centre and we will be happy to discuss these with you.